Over the years, I've gained so much from so many, some amazing people in my life who have cared with boundless love. Eternally grateful I am to them. I'm also thankful to the teachers who have given without holding back. So, can I give something back? I certainly hope so. Hopefully, this will be helpful to some young physicians in their clinical journey and in their exam preparations. That for me would be amazing. Today's presentation would be on urinary anion gap concepts and analysis. Serum anion gap was discussed a few days ago. While interpreting an ABG, these would be the steps that I would always follow. All the steps and the process have been explained in previous videos. The concepts of electroneutrality and the balancing act of anions and cations have been discussed in detail in the previous video. Kindly have a listen. However, in summary, the total number of cations in the body, be it serum or be it urine, are equal to the total number of anions in the body. The second important concept is that if a cation reduces in number, another cation increases in number and fills the gap. Similarly, when an anion decreases, another anion increases in number and fills the gap. So, if the total number of anions are always equal to the total number of cations, how do we have an anion gap? So, the reason for that is what we measure, the measurable total cations are more than the measurable total anions. So, the difference is only in what we measure, and it's only an apparent gap, not a real physiological gap. This slide was explained in detail in the previous presentation, but I'll just summarize here. So, every one of us has an anion gap range. That's because the measured cations are more than the measured anions, even though the total cations always in physiology and pathology equal total anions. It's just because the measured component has a gap, we have an anion gap. As in the serum, we do have an anion gap in the urine as well. As in the serum, the sum of cations equals the sum of anions in the urine as well. So a urinary anion gap formula is different to the serum anion gap formula. Here the formula is sodium plus potassium minus chloride. So the difference between the sum total of the measured cations, sodium plus potassium, from chloride will give the urinary anion gap. So sum of cations being equal to sum of anions, we do have the formula sodium plus potassium plus unmeasured cations are equal to chloride plus unmeasured anions. Rearranging this formula, we would get a formula that says the urinary anion gap is equal to sodium plus potassium plus unmeasured cations minus chloride plus unmeasured anions, which is again rearranged to show sodium plus potassium minus chloride will equal unmeasured anions minus unmeasured cations. How we arrived at this particular formula, I've shown it step by step. Have a look. So the formula for a urinary anion gap is sodium plus potassium minus chloride. Sodium and potassium being the measured cations and the chloride being the measured anions. When you use the unmeasured component, it's the unmeasured anions minus unmeasured cations. You do have to remember that the component of unmeasured anions are much more than the component of unmeasured cations. If you look at it logically, it does make sense. The measured component of the cations are much more than the measured component of the anion chloride. So you have a large component of the measured cations and a smaller component of the unmeasured cations, and you have a smaller component of the measured anion and a larger component of the unmeasured anions. The unmeasured anions are more in number than the unmeasured cations. That's why you have a urinary anion gap that says unmeasured anions minus unmeasured cations, which is the same for the serum as well. Under normal physiological conditions, the sum total of urinary sodium and potassium exceeds the total of urinary chloride. Thus, in normal physiological conditions, we do have an anion gap, which is a measured difference. The above statement holds true even for renal tubular acidosis. How so? We would explore that in a bit detail in the following slides. When we do identify metabolic acidosis, and if you identified a high anion gap metabolic acidosis, it's got a different pathway which has been discussed in detail in multiple presentations in previous videos. However, if it is a normal anion gap metabolic acidosis, then we go on to do a urinary anion gap metabolic acidosis. As to the causes of renal tubular acid, as to the causes of a non-anion gap metabolic acidosis, I have discussed that in detail in the previous video, but I have presented that slide here as well, just for familiarity. Have a look. So it's divided into major categories of renal tubular acidosis and non-renal tubular acidosis etiologies that cause NAGMA. The renal tubular acidosis I plan to discuss in detail in another presentation. But as to the non-RTA causes, the major pathology is gastrointestinal. Gut-related pathologies are the main cause of non-RTA related NAGMA. And towards that end, we need to keep in mind that major components of the stool are cations, sodium and potassium, which are major components of the stool, and the anion bicarbonate is much more in number than the chloride in stool. Keeping this in mind, we could understand that when a patient does have diarrhea, which is a cause of non-RTA NAGMA, they would lose large components of sodium, potassium and bicarbonate and a lesser amount of chloride in their diarrhea. So as a normal adequate response, the body would try to conserve sodium, potassium and the bicarbonate, thereby it would conserve sodium, potassium and bicarbonate, and the urine would have less amount of sodium, less amount of potassium and less amount of bicarbonate. The less amount of bicarbonate would be compensated by increasing another anion chloride, and the reduction in sodium and potassium would be compensated by increase in another cation, ammonia. I would come to that in a moment. The acids that we generate through metabolism are excreted from the body as hydrogen ions, which combine with the ammonia that is generated in the proximal convoluted tubule and forming ammonium. Hydrogen ion combining with the NH3 forms ammonium. So what we excrete reflects what we consume. So normal diet has more sodium and potassium than chloride. Hence the urine will have more sodium and more potassium than chloride, and thus we would have a measured gap reflecting a measured urinary anion gap. The ammonium is usually excreted as chloride. However, there are other combinations as well, such as the other anions, ketoacid anions, sulfate, hippurate and citrate. This particular fact that we just mentioned, that is that the ammonium being excreted apart from with chloride with the other anions as well, is the reason that we have another measurement or another concept called the urinary osmolar gap. The urinary osmolar gap is a more accurate reflection of the ammonium that we excrete, because it takes into account not only the chloride but the other anions as well. How we would discuss the urinary osmolar gap and the serum osmolar gap in detail in coming presentations. Alright, let's see how we could integrate the urinary acid excretion into the urinary anion gap concept. The urinary anion gap formula is urinary sodium plus urinary potassium minus urinary chloride. The major form of urinary acid excretion is as ammonium, which we already know. And ammonium is chiefly excreted as ammonium chloride. We do know that as well. Thus, urinary acid excretion is urinary ammonium excretion, which is urinary ammonium chloride excretion. Does that make sense? And thus, urinary acid equals urinary ammonium, which equals urinary chloride. Now, if I say the measurable urinary chloride is a surrogate marker of urinary acid excretion, would you agree? So, if there is more urinary chloride, there is more urinary ammonium and more urinary acid. So that's the concept of urinary anion gap and acid excretion. Now I'm going to make another statement saying that the urinary anion gap is always positive in renal tubular acidosis and negative in non-RTA gut pathologies. So the gut pathologists have a negative urinary anion gap, and remember that gut negative. This will be very useful when you are confused in an exam scenario. At least you could remember the gut pathologists, that is non-RTA pathologists, have a negative. The gut pathologists have a negative urinary anion gap. I did make a statement saying that the renal tubular acidosis would always have a positive urinary anion gap. I'm going to see whether I could actually explain that a bit further. Before going into that, okay, let's quickly revise that the normal response to a metabolic acidosis is to try and increase the urinary ammonium excretion, because the urinary ammonium excretion is urinary acid excretion, which is a urinary chloride excretion by surrogate. Okay. Now, measurement of urinary anion gap or the urinary osmolar gap, which is a better reflection of all types of ammonium excretion, is helpful in evaluating a patient with normal anion gap metabolic acidosis. Okay, because that will give us an idea about the amount of ammonium excretion, which is the amount of acid excretion. We'll explore these concepts a bit further. Okay, so I did make a statement that the renal tubular acidosis will always have a positive urinary anion gap. Why so? Because RTA is a defect of acid excretion. If it's a defect of acid excretion, it's a defect of ammonium excretion. If it's a defect of ammonium excretion, it's a defect of ammonium chloride excretion. So the urinary chloride levels would be low. So you'll have higher levels of sodium and potassium and low levels of chloride. So there would be a gap. Okay, so the sodium and potassium would be more than the amount of chloride, and you would have a gap. That is why renal tubular acidosis, which is a defect in acid excretion, which is a defect in chloride excretion, will have less chloride and will always have a positive urinary anion gap. Emphasizing that point again, so urinary acid excretion is urinary ammonium excretion, which is ultimately surrogate marker for urinary chloride excretion. Okay, so the RTA is decreased urinary acid excretion, which is ultimately a decreased urinary chloride excretion. Thus, you will have a positive urinary anion gap in RTA always. Alright, now looking at this diagram, look at the right, okay, towards our right. So, okay, if you look at it, it reflects the amount of sodium and potassium. Okay, more amount of sodium and potassium as usual are excreted. Okay, the defect is only in acid excretion. So sodium and potassium are excreted as usual. The PCT is functioning normally. Okay, we will look at the defect in RTA, various pathologies later, but here sodium and potassium are being excreted normally and ammonia is less, so that space is taken up by sodium and potassium as well, and because the ammonium is less, you could see that the chloride is less. So there's a huge gap between sodium and potassium minus chloride, and that space is taken up by an unmeasured anion. Thus an RTA will have a positive urinary anion gap always. Okay, the gut pathologist will have a negative. The gut pathologist will have a negative anion gap, and I'll come to that in a moment. Now coming on to the non-RTA causes, that is gastrointestinal or gut pathology causes. When you do have chronic diarrhea, you do lose bicarbonate and you have a metabolic acidemic state, and as an appropriate response, the body will try to excrete the acid, that is, the body will try to excrete hydrogen ions and ammonia and combining into ammonium. So that's an appropriate response. The ammonium will combine with chloride and the urine will have higher amount of ammonium chloride. Okay, and then the urine would also, and the body would also try to excrete to conserve the bicarbonate. So you would have less bicarbonate in the urine and more chloride in the urine. Okay, the ammonium is often excreted as chloride, but it does get excreted as other anions as well, which is why we do have a concept called the urinary osmolar gap, because that better represents the amount of ammonium that is in total excreted along with chloride and the other anions, we would come to that concept, that is to the urinary osmolar concept, on another day, and we will look at the RTA as in detail as well on another day. Now continuing on to the non-RTA NAGMA pathology of urinary anion gap. So the sodium, potassium and bicarbonates are lost in diarrhea, and hence the urine attempts to conserve sodium, potassium and bicarbonate, which is a normal response. Remembering that the urinary anion gap formula is the total of sodium plus potassium minus chloride. To compensate for the conserved bicarbonate, the chloride is lost as a balancing act. So you have less amount of the cations, sodium and potassium, and more amount of the anion chloride. So also to mitigate the acidemia, the body appropriately responds by enhanced acid excretion, which is in fact enhanced ammonium and chloride excretion. So thus in total, if you look at the diagram that is beautifully depicted on the left side, you have a total reduction in the amount of sodium and potassium, and that space is taken up by ammonium, which is of course unmeasured. So you have a big gap there. Then you look at the chloride, which is significantly increased. So the amount of chloride is much more than the amount of sodium and potassium. Thus there is a reversal of the anion gap. Urinary anion gap is reversed. So you would get a negative urinary anion gap in gut pathologists. Let's remember that gut pathologists of non-RTA causes have a negative urinary anion gap. If you get stuck in an exam situation, remembering gut has a negative urinary anion gap would help you kickstart the other concept and remember the other concepts. So this is a beautiful visual demonstration of the concepts that we discussed previously. So in RTA causes you have a large gap, and in non-RTA gut causes you have a reversal of the anion gap, which is a negative anion gap. We've discussed these concepts previously. Have a look, and visual memory always helps, so I put this slide here. This is again a visual depiction of the concept that we discussed of RTA and non-RTA NAGMA having urinary anion gaps, positive and negative. Have a look. This is a revision of what we've already discussed. So in RTA and normal physiology, you would always have a positive urinary anion gap, and in non-RTA, you would have a negative urinary anion gap. This is just to revise the non-RTA or extrarenal causes of a NAGMA. So they are mostly or major causes are gastrointestinal, just for revision. This is again another slide just to revise the causes of NAGMA, major being types RTA, type 1, type 2 and type 4, and non-RTA causes. We would of course discuss in detail about the RTA in another presentation. I wanted to introduce the term voltage dependent renal tubular acidosis, which is a term very commonly used in literature nowadays. This actually would come under renal tubular acidosis type 4, but just have a look and get used to the term voltage dependent renal tubular acidosis, which we would look in detail in another presentation. This is for visual depiction, revision purposes for the diarrhea and renal tubular acidosis of NAGMA, how the urinary anion gap is represented. Just recollect what we've discussed and have a look. It will help you remember. This slide is to introduce the numbers involved with a positive urinary anion gap, which is usually between plus 20 and 90. So if you have a positive urinary anion gap, you expect a value to be more than plus 20. And if you have a negative urinary anion gap pathology, you generally expect a number to be lesser than minus 20. That is, it could be minus 30, minus 40 or minus 50, but lesser than minus 20. So more than plus 20 for positive anion gap, less than minus 20 for a negative anion gap. Results between plus 20 and minus 20 cannot be reliably interpreted. This is taken from UpToDate. Eternally grateful to the love shown and sacrifices made by some amazing people in my life. I'm eternally grateful. Thank you so much. Did you find this presentation beneficial? If you did so, and if you liked it, kindly hit the like button and subscribe. These are some of the topics I plan to present in coming days, in particular the osmolar gap and approach to renal tubular acidosis in a detailed manner, and the other renal channelopathies. If you do have any particular topic that you would like to be covered, kindly let me know. Thank you for your patience. See you another day.